and welcome to Clerkship Ready Pediatrics, a podcast aimed at helping you excel during your clinical clerkship in pediatrics. I am Jared Barkus, a child neurology resident at the University of Virginia, and today we'll be talking about how to master the neuro exam. At some point during your pediatric clerkship, a patient will have a chief complaint that will require the completion of a neurologic exam. So this episode will focus on helping you to begin thinking like a neurologist. First, we will go over a quick review of the nervous system before we dive into talking about completing your first neuro exam, covering some key points as well as common abnormalities and what they may mean. Of note, I am going to be going through a formal neuro exam, which you can do with an older child, adolescent, or adult, since they are usually the goal of the exam. Finally, we will wrap up by touching on how to approach the neuro exam in a young child who may not be able to fully participate in a formal neurologic exam. But before we start, let's take a moment to frame how to start thinking like a neurologist. I like to explain that being a neurologist is sort of like being a detective. Often, as a neurologist, you are trying to piece together patient complaints or symptoms, parental observations, and your exam findings to fit the map in your head of how the brain and nervous system work. Important elements like the timeline of symptom onset, patient descriptions, exam findings, and imaging studies are all just pieces of the puzzle. Also, some neurologic complaints have a unique interplay with other systems, such as the cardiovascular, immune, and endocrine systems. Diseases like multiple sclerosis or diabetes-induced polyneuropathy present primarily with neurologic deficits, but are treated by addressing the problems with either the immune or endocrine system. Also, always keep psychiatric conditions in mind when considering possible abnormalities or patient experiences. Patients with chief complaints such as seizure-like movement or inability to walk, but that have a neurologic exam that is inconsistent with their experiences, may benefit more from treatment of their anxiety or depression rather than invasive neurologic scans or tests and/or side effects of anti-seizure medications. Now, with that out of the way, let's review the map. For me, the nervous system is broken into 5 different parts: the cerebellar cortex, brainstem, spinal cord, nerve roots and tracts, and finally, the neuromuscular or neurosensory junction. While I could spend an entire hour speaking about each of these different sections, we will quickly review the high points of each area of the nervous system. The cerebellar cortex can be separated into 4 major regions: the frontal lobe, temporal lobe, parietal lobe, and occipital lobe. The frontal lobe is the primary portion of the brain that controls cognition, orientation, reasoning, and other higher cognitive functions. Damage to this area can present as disorientation to person, place, or time, and/or changes in a person's behavior. The primary motor cortex, which controls motor planning and sends signals for the body's movement, is located just anterior to, or in front of, the central sulcus, making it a part of the frontal cortex. Broca's area, which is an important part of the motor planning for speaking, is located to the left lateral portion of the frontal cortex. The temporal lobe is the portion of the brain focused on memory, language, and the processing of sounds. Wernicke's area, which controls word association and sentence structure, is located in the superior portion of the temporal lobe. The parietal lobe is the primary sensory cortex of the brain, where sensory input from the body, such as touch, pressure, heat, cold, and pain, is received and processed. Finally, the occipital lobe is the portion of the brain that focuses on processing the visual information sent from the eyes. Cortical vision damage can lead to an abnormal visual interpretation and misrepresentation of visual signals coming from the eyes. The next important area of the map is the brainstem, which consists of 3 main portions: the midbrain, the pons and cerebellum, and the medulla, and also contains the 12 cranial nerves. The most superior portion is the midbrain, which provides passage of the cortical fibers descending to the body and the sensory fibers ascending to the brain. The midbrain is just inferior to the thalamus, epithalamus, and hypothalamus areas. Cranial nerves 1 and 2 are located above the midbrain. Cranial nerves 3 and 4 are located in the midbrain. The pons and cerebellum are located below the midbrain. The pons houses several cranial nerve nuclei, as well as nuclei responsible for respiration and other important bodily functions. The cerebellum, which sits at the back of the brainstem, primarily responds to proprioception and position sense signals coming from the body, as well as smooth movement signals sent down from the cortex. These functions allow for balance and coordinated movements. Cranial nerves 5, 6, 7, and 8 are located in the pons. The final portion of the brainstem is the medulla. The medulla serves as the connection point between the brainstem and the spinal cord, housing several of the motor and sensory fiber tracts. Cranial nerves 9, 10, 11, and 12 exit this area of the brainstem. We will review the cranial nerves in more detail while discussing the neuro exam later in this episode. But as a quick review, the 12 cranial nerves are lower motor neurons that exit the brainstem and serve different function in several essential body systems such as smell, sight, taste, respiration, parasympathetic, sympathetic nervous systems, as well as provide movement and sensation to the face. The spinal cord is the next stop on our neurologic pathway and is the communication tract that houses the lower motor neuron cell bodies of the sensory and motor systems. The spinal cord works to communicate sensory signals up to the brain via the afferent pathways and motor signals to the muscles via the efferent pathway. The idea of afferent versus efferent pathways can often be confusing, but one easy way to remember it is that afferent information arrives and efferent information exits the spinal cord. These lower motor neuron bodies will send nerve roots out the sides of the spinal cord to form nerve tracts. Finally, these nerve tracts will terminate in either the motor neuron unit or specialized sensory receptors located throughout the body. And that's it! By knowing and understanding how the neurologic map of the body works and connects, you can begin to think and even localize abnormalities noted on the neurologic exam to specific areas or regions in the nervous system that may be damaged. One tip before we start speaking about the formal neuro exam is how to answer the dreaded question of ipsilateral versus contralateral. While there are always exceptions, in most cases, damage to a majority of the nervous system will result in contralateral deficits on the neuro exam. In other words, damage to the left side of the brain results to right-sided findings. Notable exceptions are damage to any of the cranial nerves, nerve roots, or damage to the spinocerebellar tract or cerebellum. While the only true way to answer every one of these questions correctly is to fully understand the different pathways and tracts of the nervous system, if you don't know, in general, damages above the medulla cause contralateral deficits, and damages below the medulla cause ipsilateral deficits. A second area that is commonly tested and asked about is whether the damage involves an upper or lower motor neuron. While there are more complex ways to think about how to answer this question, the quickest way is to think about this. The cortex works to suppress your body's natural reflexes to allow coordinated movements. Thus, damage to the upper motor neuron or cortex portion causes symptoms to go up or increases reflex, tone, and spasticity. Whereas lower motor neuron damages causes symptoms to go down, decreased reflexes, lower tone, or spontaneous movements. Now, with a solid foundation of the map of the nervous system, we can begin to discuss completing the neuro exam. First and foremost, a quality neuro exam, when completed in a systematic, head-to-toe approach, should serve as a means of evaluating each major portion of the nervous system to identify new deficits or weaknesses, as well as serve as a means of tracking progression of symptoms or damages over time. Thus, each time you complete a neuro exam, you should complete it in the same way, regardless of the patient's chief complaint, especially if the patient has a visible or obvious deficit, so that you avoid missing any subtle neurologic abnormalities, which could change your differential diagnosis and or the diagnostic and treatment plan. The typical neuro exam should be seen as a screening exam that can be used to identify any area of concern. Once that area has been identified, other more specific tests or exam maneuvers may be helpful in further diagnosing the patient's deficits. So, while the neuro exam will pick up most things, it may not pick up everything. So remember to always take the patient's clinical picture as a whole when considering or deciding the possible differential diagnoses. While most neuro exams you will complete as a medical student will be conducted with willing participants like adults, I think it's important to also cover some tips and tricks on how best to adapt the neuro exam in order to assess the neurologic abilities of children. The two most important things to understand when completing a neuro exam in children are that observation will be your best friend and you must make it fun. While you may not always be able to get your patient to understand or participate in a formal finger-to-nose exam, through careful observation, you can still assess a number of different systems without doing a formal neuro exam. Important information can be understood from things like how they catch a ball or walk, whether you notice a leg or hand preference, and or if they can smoothly reach for a toy or play a game on a touchscreen or iPad. The second key to making sure you gather as much information as possible is making sure your different moves and exam feel like a game. Leave your ego at the door and start acting out the different moves you want the child to do. Walk like a duck. Flap your wings like a chicken. You will be surprised how quickly a child will start copying you. We all remember as a kid nothing being more interesting than a game that we are invited to play with new friends. So use that to your advantage. Now, on to the exam. The neuro exam begins the moment you walk into the room and see a patient. The first assessment should be the patient's general status. Is the patient alert, awake, and able to recognize that you've entered? Or is the patient conscious, but disoriented? Is the patient playing with toys, or is they slumped in their parents' arms? Are they moving or not? Do they appear to be responding from stimuli such as sounds, touch, or pain? Are they sedated? Do they appear to be breathing on their own? Are they in a coma? All of these general first assessments will quickly give you insight into the status of the patient's nervous system, as well as how likely they are to be able to cooperate in your neuro exam. The first and most important rule of a neuro exam is to base it on your patient. Patients who have altered mental states of consciousness, such as being encephalopathic, which is a broad term meaning that their brain is being negatively affected by some chemical imbalance or toxin buildup, or a patient that is sedated or in a coma, should be evaluated based on the response to stimuli, using something like a Glasgow Coma Scale rather than a formal neuro exam. Pediatric patients should be evaluated based on their age and developmental status. For example, a 6-month-old patient should not be expected to walk or talk, and a 15-month-old who occasionally stumbles should be seen as normal. Remember to review some of your developmental milestones prior to completing a neuro exam on a patient in order to better understand what they should and shouldn't be able to do at their current age. Next, assess the patient's orientation. This can be as simple as asking the patient why they have come to clinic. A patient who accurately and quickly provides a recent history of their symptoms and the events leading to their presentation is oriented to person, place, and time. In patients who have challenges answering these questions, specific orientation questions like, where are we? What day, month, and year is it? Can be a quick way to gauge the patient's orientation. Most often, patients will lose orientation to time first, then place second, and finally to person. In pediatric patients, this can be accomplished by asking them what they are doing or the name of animals and toys from a book. Sometimes your best resource will be the parent. You can ask if the child has seemed confused or if they seem to be behaving abnormally. Note, again, some things are difficult to assess based on the patient's age. You need to remember that some complex ideas that we as adults take for granted, such as time and orientation in space, require the development of those ideas in children. Complex thoughts like object permanence and the idea of self may not be developmentally appropriate based on the patient's age. Any abnormality in a patient's level of consciousness and orientation can be a sign of some sort of issue impacting the cortex, such as a large area stroke or encephalopathy. Next, evaluate the patient's speech. How do they answer questions? Are they able to quickly and accurately answer questions with articulate answers? Or is their speech slowed, words jumbled, speech difficult to understand? Do they have issues hearing your voice or understanding your question? Are there any deficits in how they move their mouth or tongue to form words? All of these can be signs of either cortical problems, hearing problems, or motor problems preventing speech. Again, in pediatrics, the parents will be a great resource here, as they can comment on how their current speech matches up with their typical baseline. Remember to think about important areas of control for speech when evaluating it. Broca's area, which when damaged leads to an expressive aphasia or inability to formulate words, may produce a patient that is able to follow directions but can't speak. Damage to Wernicke's area can produce a patient that's lost the ability to associate meanings to words, leading to a patient that's unable to follow directions but can still create nonsensible sentences with well-articulated words. Meaning if you ask the patient, "How did you get here?" they might respond with something like, "You aren't being since the extra little face wants something if I know." This is a symptom that is referred to as a word salad. Language is a complex but important element of our conscious mind and takes up a large portion of our cortical processing. Gaining an understanding of the patient's ability to understand, process, formulate a response, and articulate that response gives you insight into a large portion of their cortical region. The final element of screening for cortical dysfunction is assessing memory. This can be accomplished by telling the patient you would like them to remember 3 words. Once they are ready, you can tell them the 3 objects, such as baseball, tree, window, and have them repeat it back to you at 1 minute and 5 minutes. Again, with pediatric patients, parents can be really great resources and can tell you if they've noticed that their child just can't remember things as well as they usually do. If at any time you identify what appears to be cortical slowing or deficits, a more formal mini-mental status exam should be completed to further classify the severity of their cortical dysfunction. We're not going to go through that today since we don't generally have to do that in pediatrics, but it is a good thing to talk with your resident or attending about if you think that someone needs one done. After completing an assessment of the patient's general status, orientation, understanding of language, and memory, you can move forward with the rest of the neuro exam, with the knowledge that the patient with any of the deficits in these cortical regions will have trouble completing a number of the exam portions that require the patient to follow directions with the examiner. Now, on to assessing the different cranial nerves. Cranial nerve 1 is the olfactory nerve, responsible for the sensation of smell. Isolated anosmia is rare and is often only tested based on the patient's complaint. Otherwise, this is typically skipped. A recent but common cause of temporary anosmia is COVID-19 infection. Uncommon causes of anosmia are head trauma, which can cause shearing of the delicate nerves of the olfactory bulb. Congenital anosmia is associated with something called Kalman syndrome. Cranial nerve 2 is the optic nerve, responsible for vision. Testing of visual fields is completed by introducing fingers into the patient's 4 visual quadrants of each eye and asking the patient to identify how many fingers they see. The examiner should use their visual field as a frame of reference for normal peripheral visual fields. In other words, if you are standing in front of the patient and you see the fingers of your visual field, but the patient cannot, assume that they have deficits in that visual region. Most informal visual field testing like this can only interpret visual field deficits into quadrants, such as the upper, lower, middle, or lateral visual quadrants. Pupillary response to light is also an assessment of the ability of the optic nerve to sense stimuli, as well as cranial nerve 3 to create the appropriate response, pupillary constriction. Damage to the retina, optic tract, optic chiasm, and optic radiations can be identified with visual field testing. However, more formal visual testing may be indicated with an ophthalmologist based on the localization of the deficit. Loss of the lateral fields of the visual fields in both eyes is associated with optic chiasm damage and is often indicating a pituitary mass compressing at the chiasm. Cranial nerve 3, 4, and 6, or the oculomotor, trochlear, and abducens nerves, are associated with movement of the eye. These are assessed by having the patient track objects or a finger with their eyes without moving their head. Both eyes should track smoothly and with good conjugation, meaning that they move together and in the same direction. through a full range of motion of the ocular movements. Any disconjugation, or the eyes not moving together, or nystagmus may represent a problem with the cranial nerves or their connection pathways. Note, horizontal nystagmus, or vibrating of the eyes horizontally with movement, may be normal depending on age. However, vertical nystagmus is never normal. Let's quickly review some common problems with cranial nerves 3, 4, and 6. As a pediatrician, strabismus, or eye misalignment, such as inturning, esotropia, or outturning, exotropia, while the child is focusing on an object, will be one of the more common eye movement abnormalities that is important to identify. Notable findings such as ptosis or partial closing of the eye may indicate damage to cranial nerve 3. An eye that's stuck inferior and laterally indicates that loss of cranial nerve 3's motor function. A sluggish pupillary response that indicates a problem possibly in cranial nerve 2 or cranial nerve 3. The inability to move an eye completely inferiorly may indicate an issue with cranial nerve 4. This is often associated with patients that report that they have difficulty walking down stairs or seeing their feet when they're moving down. The inability to move an eye laterally may indicate a problem with cranial nerve 6 or the abducens nerve. If trying to assess the oculomotor nerves of a child, it may be useful to have them track your face or a bright flashing toy around the room to help assess cranial nerves 2, 3, 4, and 6. A child as young as 2 months of age will naturally track faces. They find them interesting, and it is one of the first things that our brains is trained to recognize. This is also a great chance to make a funny face or do interesting things to get their attention. Simple moves like covering one of the patient's eyes and switching to the other one can give invaluable information and help diagnose things like strabismus. But for the child, it will just feel like having a fun game being played with them. Cranial nerve 5, the trigeminal nerve, is separated into 3 branches and is responsible for sensation of the face as well as sensation of the cornea. The checking of a corneal blink reflex is often reserved to patients only in a coma. Sensation of the face should be assessed by light brushing of the forehead, cheeks, and jawline bilaterally, asking if the patient can sense touch in each region. In a child, if they turn their head or show some sort of response to stimuli when touched on the face, it can be assumed that they have good sensation. Any abnormalities that are noted on this screening exam should be followed up with a formal sharp versus soft examination in the 3 regions, which you can do on maybe an older child or adolescent, but should probably be deferred in a very young child, particularly because they're just going to cry the second you poke them with something sharp. Cranial nerve 7 is the facial nerve and is responsible for movement of the face. A patient's face should be assessed for any asymmetries while opening or closing the eyes, as well as changes when smiling or frowning. In a pediatric patient, this may only be able to be accomplished through observation, but you should look for any asymmetry as the child makes faces or even as they cry, as this can be important information. An isolated upper facial paralysis is often due to contralateral cortical damage, indicating an upper motor neuron damage. A patient with both upper and lower face involvement is often seen in ipsilateral facial nerve damage or something called Bell's palsy. Cranial nerve 8 is the vestibular cochlear nerve and is responsible for hearing as well as balance based on head position. Often, the hearing portion is assessed by the patient's hearing being intact to conversation, finger rub near the individual's ear, or more formally with a tuning fork. Cochlear damage can be identified by symptoms of vertigo or nystagmus with movement of the head or eyes. In children, we may be able to have them turn their head to near sounds. So, by sitting the patients in their lap and walking behind them and clapping your hands or calling their name, it can give you a quick idea of whether they hear you and turn appropriately to the sound. Nystagmus, that is fatigable, meaning that the nystagmus stops after the patient stops moving their head or eyes, indicates a peripheral nervous system problem, most likely located in the cochlea or otoliths. Non-fatigable nystagmus, or nystagmus that continues regardless of if the head is still, is often due to a stroke in the brainstem. Cranial nerve 9 is the glosopharyngeal nerve and is responsible for sensation within the nasopharynx and taste at the posterior portions of the tongue. Primarily assessed by completing a gag reflex, however, Unless there is a specific concern with cranial nerve 9, most awake patients prefer not to have their gag reflex tested. Thus, cranial nerve 9 is often skipped unless the patient is in a coma. Cranial nerve 10 is the vagus nerve and is responsible for a majority of the parasympathetic signals to the central organs such as heart and GI system. It is also responsible for symmetric rise of the palate. Thus, cranial nerve 10 is often evaluated by having the patient say, ah, and assessing for the rise of their palate with any deviation of the uvula. Raising of the palate is a pulling movement, and so any cranial nerve 10 damage will lead to deviation of the uvula away from the damaged side. Cranial nerve 11 is the accessory nerve and should be assessed by having the patient shrug their shoulders or turn their head into resistance provided by the examiner. Cranial nerve 11 controls muscles which again create a pull function, and so any ability to turn the head left would be associated with a right-sided accessory nerve problem. Finally, cranial nerve 12 is the hypoglossal nerve and is associated with having the patient stick their tongue out past their lips. During this movement, the tongue should remain midline. The movement of the tongue is a push movement, so any deviation of the tongue would be toward the side of the damage of the hypoglossal nerve. The tongue is also the best place to see fasciculation, which is often associated with a problem at the neuromuscular junction. If you have never seen fasciculations before, now is an excellent time to look up a video, as this is an exam finding that is a cannot miss, because this could mean something very serious like spinal muscular atrophy or ALS. We have now completed the cranial nerve exam. While there are a lot of things to assess, the actual assessment of the various cranial nerves only takes a few minutes. Early on, it may be easiest to remember the various steps by listing the cranial nerves in your head as you go through. Again, if you're trying to assess the cranial nerves of a child, it can be useful to act out the movements you want the child to do with their face, or even making them laugh by tickling them can be a useful way to gain information about asymmetries or abnormalities with their cranial nerves. Now that we've completed the cranial nerve assessment or examination of the head and neck, it's time to assess the patient's strength in their upper and lower extremities. Before testing this strength, it is important to understand the rating system used to understand exactly what we're assessing. Strength classification is graded on a scale of 0 to 5, representing increasing strength. Grade 0 represents a total paralysis. Grade 1 is if there is visual or palpable muscle contraction, but no active movement across the joint. Grade 2 is if there is active movement across the joint with a full range of motion, but only if gravity is eliminated from the equation. Grade 3 is if there is active movement with full range of motion against gravity, but without any resistance. So again, if you are testing the strength of the arm, you will hold and support the patient's arm at 90 degrees in front of the body, with the arm flexed so that their hand is next to their shoulder, and having them extend their elbow and move it against the force of gravity. Grade 4 is if there is active movement with full range of motion against some resistance provided by the examiner, but not full strength. Finally, grade 5, which is perfect or normal strength, is if there is active movement across the full range of motion of the joint against active resistance provided by the examiner. Strength should be assessed by testing the various spinal segments that control the nerves. However, remembering the cervical and lumbar segments and nerve innervations is very challenging. Thus, most people remember the strength exam by simply testing strength across each joint, meaning testing the patients at their shoulders, elbows, wrists, fingers, hips, knees, ankles, and toes for strength. Remember, particularly in young kids, acting things out and turning this portion of the exam into a game is a great way not only to communicate the movements, but also help improve the patient's effort and cooperation with the exam. One way I use to remember the various strength movements is by visualizing the different patient positions used to isolate these different muscle groups. That is, chicken wing, testing the shoulders, pushing up against resistance. Boxer, testing the push and pull ability across the elbow against resistance. Motorcycle, testing the patient's ability to flex and extend the wrist against resistance. Splat, testing the patient's extension of fingers against resistance by pushing them back together. OK, testing the strength of the PIP joint by trying to break an OK symbol made by the patient. And squeeze, testing the patient's grip strength by having them grip two of the examiner's fingers. A small note here, always have the patient squeeze any two of your fingers overlapping one another, as it's very difficult for the patient to accidentally damage the examiner's finger in this way. Legs are tested by remembering these movements. Knees up, testing the strength of the hip against resistance. Kick out, testing the strength of extension at the knee. Pull in, testing the strength of flexion at the knee. Toes up, testing the ability to flex the ankle against resistance. Gas pedal, testing the ability to flex the ankle down. And wiggle your toes, testing the strength of the toes against resistance. The goal of the strength testing is to attempt to identify any weaknesses or wasting of the muscles, paying attention to which side of the body is affected, as well as whether it is an isolated upper or lower limb weakness, or if both the upper and lower limbs are involved. Hemiplegia, or loss of the upper and lower limbs on one side, is often damage to the brainstem on the contralateral side. Isolated upper or lower limb damage can often be seen in either middle cerebral artery strokes if the hand and arm is involved, or anterior cerebral artery strokes if the legs are involved. After or while examining strength, you should also attempt to identify any abnormalities of tone or spasticity, which are assessed by passively moving the arms and legs across multiple joints. Tone is a natural resting level of contraction that we all have in our muscles. Some patients will have very little tone, which can be felt as joints or limbs that are very loose when passively moved. Some patients will have too much tone, which will be felt as really difficult to move arms or legs as they passively flex or extend across a joint. Spasticity is easily confused with tone. However, uniquely, spasticity is considered a velocity-dependent catch experienced when the joint is moved very quickly. Patients with upper motor neuron damage will have different levels of spasticity as well as motor weakness that can be noted on the tone, spasticity, and strength portions of the exam. Tone in babies is often assessed by feel, but there are some movements that can be very useful for assessing tone. Moving a baby's arm across midline can check for decreased tone or increased tone. Most babies should be able to move their arm across the midline with their elbow coming in line with their chin prior to meeting resistance. Anything past this could indicate hypotonia, and anything before this could indicate hypertonia. Other commonly tested exam findings, such as head lags, is where the baby is lifted by their arms and looking for if their shoulders do not tense and their head flops back. Or something called a positive slip-through sign, when you pick the baby up from their underarms and you feel them slip through their hands, can be an indication that they have too little tone in their shoulders or arms to provide the appropriate resistance. While identifying low or high tone in babies is rather difficult early on, it can be useful to practice often by assessing the tone of normal babies so that you get a better feel for what the tone should be and may be able to identify a baby with high or low tone in the future. The next step would be to assess sensation. This is often completed by simply doing a finger touch to the skin of the arms and legs to assess the patient's ability to identify sensation in their upper and lower limbs. Again, similar to when we were discussing sensation in the face, a more formal sharp versus soft evaluation may need to be completed based on the patient's chief complaint or if there are any deficits on this rough screening exam. Following a quick assessment of the patient's sensation, the next step will be to assess the patient's coordination. Coordination exam maneuvers primarily focus on assessing the patient's ability to sense their arms and legs in space and relay that information appropriately to the brain to create smooth and coordinated movements. Most problems with coordination indicate an issue with either the cerebellum or its processing of information and smoothing of movements sent down from the brain. Coordination is primarily assessed by completing a finger-to-nose testing. It is important to know that the examiner should be sure to keep their target finger at the extremes of the patient's wrist to assess their coordination with their arm fully extended. Common errors can be seen in simple things like inaccuracy at the nose or at the target finger, or more complex things such as pass pointing, which is missing the target finger by overshooting. Often, these can indicate an issue with the cerebellum on the same side of the affected limb, which makes the cerebellum one of those exceptions to the typical contralateral rule that we discussed earlier. The lower limb coordination can be assessed by completing a heel-on-shin rub, which should have the patient run the heel of their opposite foot from the knee down to the ankle bilaterally. Again, looking for any error in their ability to keep the heel connected to the shin throughout the length of the movement. When trying to assess coordination in young children, it may be useful to throw or kick a ball, try running, or even have them reach out for a toy or an iPad with either of their hands in order to assess these things like coordination. This can be very challenging to assess because children will have different levels of coordination based on their age and developmental status. Finally, an assessment of the ability to complete rapid alternating movements is important by having the patient complete something like a hand flapping. An abnormality would be noted as fast movements followed by a much slower, less coordinated movement, which could indicate a problem with the cerebellum. This is also known by the much fancier term dysdidactokinesia. Moving on to the last portions of the exam, the patient's gait and balance should be assessed by having them walk a few steps, looking for smooth walking movements, as well as observing for any obvious signs of instability or balance issues. Finally, a Romberg assessment should be completed by assessing the patient's ability to balance when their visual input is removed by having them close their eyes. When trying to assess the gait and balance of a child, again taking into account the patient's developmental age as well as input from the parents will be very important for assessing whether there is a difference in the ability of that child to balance and walk based on their baseline. The final aspect of the neuro exam should be reflexes. While most trainees early on focus on eliciting reflexes because, frankly, they're kind of fun, in terms of your assessment, reflexes should be seen as a cherry on top of your already working differential diagnosis. All of the information that you've gathered up to that point should put you towards what you expect the reflex response to be when you assess the patient. Reflexes are often assessed after strength and are graded on a scale of 0 to 4, with 2 being a normal reflex value, allowing for us to indicate whether the patient has hypo or hyper reflex function. Hyporeflexia may indicate damage to the sensor or motor nerve at the level of the spinal cord. Hyperreflexia often indicates damage to the cortex or brainstem, leading to disinhibition of the reflex arc. Reflexes are graded as follows. Grade 0 is no reflex response whatsoever. Grade 1 is slightly diminished reflex responses. Grade 2 is a normal reflex response. Grade 3 is increased reflex response. And grade 4 is if there is clonus present. Reflexes that are commonly tested are the brachioradialis and tricep reflexes in the upper extremities and reflexes at the knee as well as at the ankles in the lower extremity. It should also be noted that the reflexes of children is slightly different than the reflexes of adult. Note that children often at baseline are hyperreflexive when compared to their adult counterparts, and the younger they are, the more reflexive they may be. Thus, a grade 3 reflex in a child may be normal, as well as a couple of beats of clonus in a young infant. If at any point you have concerns about the reflexes of your patient, particularly a pediatric patient, be sure to grab your resident, attending, or even a friendly child neurologist to have them check it as well. And that's it. You've finished a complete neuro exam. While the number of steps involved and the detail-oriented nature of the assessment often seems daunting and time-consuming early on, with practice, you will be able to complete this in approximately 10 minutes with good accuracy and thoroughness. Now, while most of the neuro exams you will complete as medical students will be conducted with willing participants like an adult, practicing among children can be a great way to hone your skills of observation as well as find useful abnormalities in the future. I also want to take a small moment to talk about some of the conversations you might have while on your neurology rotation. I think it's very important to understand that any time a child is in the hospital or clinic, it can be a stressful time for that parent. But this is especially true if you're completing an exam that tests the child's brain and nervous system. Every parent worries, but conversations about children's development or ability to move or think can cause families a lot of anxiety. Questions like, will my child be able to walk, talk, do well in school, or live a normal life are common occurrences in the world of pediatrics and especially in pediatric neurology. So remember that no matter the situation, all parents can benefit from empathy, compassion, and a little bit of hope. But if you are asked a question that you don't know the answer to, be sure to defer to the resident or attending that you're working with to help prevent any unnecessary anxiety for the family. And that's it, a rapid-fire review of how to complete a neuro exam and common things to watch out for. Now, the most important step is to practice. It's great to complete a few normal neuro exams, but nothing is better and more memorable for your learning than seeing and identifying an abnormality on your exam. So always remember to go head to toe, review the neuro map, and pack your reflex hammer. I hope you have fun practicing your skills with patients, and maybe I'll even see a few of you as future child neurologists. Thanks for listening to Clerkship Ready Pediatrics. I hope you found today's podcast helpful. Don't forget to subscribe below and rate this podcast wherever you get your podcast.